The first slide is very interesting because it is not many years ago when one of the very senior professors said that the greatest danger to a man with a high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. So also a very eminent US cardiologist many years ago in the 1930s said that hypertension is only an important compensatory mechanism. So we have come a long way, ladies and gentlemen. And what is important is from 2000 to 2025, you can clearly see from 60 million odd patients with hypertension in the Indian subcontinent, we have gone to almost 100 million. And this exponential rise is more than what the other countries have gone through during the same period. What is even more lamenting that as physicians, possibly we have not been up to the mark because our awareness is low, the treatment is also low, less than 50%, and the control is abysmally low. And this is reflected both in the urban and rural. There is an urban and rural divide. However, the rural is also catching on. So we really need to do more about creating an awareness about the disease and treating this adequately. If you look at the etiological factors, you can see there's a wide array of etiology, including the sympathetic nervous overactivity. And this has been brought up in the Indian hypertension study, which was done recently and showed that Indians have almost a 60% sympathetic overactivity compared to what is seen in the Western world. And so also the importance of beta blockers. Now, secondary hypertension, obviously, I'm not going to touch, but it needs to be seen when the blood pressure is not adequately controlled by adequate doses of drugs. The determinants of blood pressure are very important because if you look at the product of heart rate and stroke volume and cardiac output, each element, for example, the heart rate, can be manipulated by medical means by the wide array of medication that we have. And the peripheral resistance, as you know, is very well manipulated by the calcium channel blockers. The RAS system is obviously central to hypertension. And if you look at the red arrows, these are the places where we can intervene in terms of the ACE inhibitors. And here the ARBs blocking the angiotensin 2 and also the aldosterone antagonists. So we have very good agents that can work in the RA system and bring down the blood pressure. The key to all this is obviously angiotensin 2, and it has a wide array of pathophysiological mechanisms that it undergoes, including the kidney and at the tissue level. And it's very important that the use of the ARBs are very important in the management of this disease. Every millimeter of blood pressure is important. And so also this graph shows you that every 20 millimeters hike in systolic and every 10 millimeters hike in diastolic creates a twofold increase in the cardiovascular risk. So it's very important as physicians to get the blood pressure down as low as possible. The permutations and combinations that are available are clearly seen in green. So you could have the thiazide with ARBs, the CCB with ARBs, the ACE inhibitors with CCBs, the ACE inhibitors with thiazide, and beta blockers, obviously not the current choice favorite, but can be used in different situations, in compelling situations. The definite thing here is you do not want to use an ACE and ARB together. Recently, obviously, we have the long-acting diuretics, and these are drugs that should be preferred in the D category compared to the routine thiazide, which are hydrochlorothiazide. So chlorthalidone and indapamide not only have a better blood pressure lowering ability, they're longer acting, and the hyponatremia risk is low. What is also true is the meta-analysis shows that only the chlorthalidone can actually decrease the coronary events and all-cause mortality compared to the plain thiazide diuretics. And as you've seen, the ambulatory blood pressure reduction is better with chlorthalidone than with hydrochlorothiazide. So we have had a lot of these guidelines, the 2013 European Society, the 2013 American Heart Association, the 2014 American Society of Hypertension, and obviously the JNC8 committee in 2014. And let's see how we can sort of integrate that. The JNC8 and the JNC7 was fairly similar in that the same 4 choices of drugs could be used. And thiazide was the initial choice for JNC7, but in JNC8, all 4 choices are available. In the ASH 2014, you can clearly see when you are less than 60 years, an ARB or an ACE is preferable. And when you cross 60, CCBs and diuretics, preferably chlorthalidone, is preferable. So also the nice British guidelines talked about the ACE-ARB less than 55 years of age, and above 55 years, the calcium channel and the diuretics. The European Society again maintains all the four categories with beta blockers in special situations. I would like to focus on the Indian guidelines of hypertension, which some of the panelists have been participated in and developed these guidelines. And this was published in February 2013, wherein younger patients, again defined as less than 55, would be better off to start with an ACE inhibitor or a beta blocker. As I told you, the Indian data shows 60% of our patients have a sympathetic overactivity. And the older patient would start off with either a calcium channel or a diuretic, again, the preference for chlorthalidone and indapamide. At step 2, you would add a C or D to A. And at step 3, you would add C and D. So it's A, C, and D in step 3. And you would add a spironolactone in step 4 if the patient is resistant hypertension. And this is also the place wherein you would start investigating for secondary hypertension. Moving on to the 2018 European Society, and this was a large task force which looked at it. And here it is grading is used, grade 1 to 3, starting at 140 and ending at more than 180. And what is also important here with the grading, they also gave us a very nice integrated method by which we could not only look at the grades, grade 1, 2, and 3, but also the stages, which was uncomplicated, asymptomatic, and established disease. And based on this, you could actually decide how early you want to intervene in terms of medication. For example, in a stage 1 uncomplicated patient with high normal BP, the patient is at low risk, and therefore medical therapy can be delayed. However, in a patient who has stage 3 established disease, even a mild increase in blood pressure is very high risk and needs to be treated. And this is the kind of recommendation that came out of it, that you had lifestyle advice for all the 4 grades, but drug treatment could be delayed in high normal and grade 1 unless it is a very compelling situation like a patient with established atherosclerotic cardiovascular disease. In grade 2 and grade 3, however, medication need to be started, preferably a single pill combination, preferably 2 medications in the initial part also. What is important to understand about hypertension is the hypertension-mediated organ damage, which is the left ventricle hypertrophy, stroke, nephropathy, and established cardiovascular disease like a myocardial infarction or patients with stenting or bypass. Compared to the 2013 and 2018, the 2018 recommendations have repeated office blood pressure measurements, automated office blood pressure measurements to avoid the use of mercury-based measurements, and also the use of out-of-office blood pressure measurements. And again, in the high normal category, to start medication early if the patient has ASCVD. And also in patients with grade 1, if they have a target organ damage, again, early institution of drug therapy is to be done. The older patients who had a little latitude in terms of the blood pressure goal of almost up to 159, here the blood pressure goals are similar and you need to start these early. So although in the 2013 less than 140 was recommended, here you could start blood pressure medication at 140 and you would really move towards 130. And this is the same thing that goes on for even the elderly patients. Well, we had a latitude of 150 in the earlier guidelines. It's now less than 140 for all age groups. And obviously diastolic blood pressure is less than 80. The more important change, however, was the SPC or the single drug combination. Here, preferably 2 drugs, either an ACE or a calcium or an ARB with calcium should be the first drug to be used. The addition of spironolactone again was new compared to amiloride in the earlier guidelines. And also device-based therapy really has a grade 3 recommendation. That means it's really not recommended compared to a very aggressive invasive procedure in the previous guideline. What it also did show is that whatever the underlying comorbidity that you have, 140 blood pressure was the treatment threshold above which you need to start treatment. There was no controversy about that. It is only relaxed to 160 if you're above 80 and frail with a low body mass index. So whatever the age, up to the age of 80, 140 blood pressure is the time to start treatment. At 80, it is more than 160, and you can go down to 135 in a patient who has high risk factors. So this is the treatment strategy here, a single pill to be used in the initial therapy in grade 1, and you could have either ACE or ARB plus a calcium channel or a diuretic. In stage 2, again, it is a simple pill, a single pill with ACE, CCB, and diuretic. And you could have 2 pills in step 3 when you have resistant hypertension. In CAD, you would institute beta blockers very early, and in CKD, you would institute a diuretic very early in this patient, making sure that you already have an ACE and CCB. In patients with the reduced ejection fraction and heart failure and hypertension, again, an early institution of diuretic and beta blocker apart from the ACE or ARB. In patients with atrial fibrillation, again, early institution of beta blocker or a non-dihydropiridine calcium channel blocker can be used. The ACC is a little different, and here we use the term stage. So normal is less than 120 and elevated is more than 120. Stage 1 is more than 130 and stage 2 more than 140. There are no grades. And when you compare both, although the treatment threshold is initially different at 130, the goals basically are still less than 130, 80. And again, the American group across the Atlantic are quite aggressive irrespective of the age group. The International Society of Hypertension 2020 is more closer home. And you had, again, the 2 grades like the Europeans. Grade 1 was anything more than 140, and grade 2 was anything more than 160. But it also gave us flexibility in terms of essential and optimal. And essential was in those spaces in rural and suburban India where you don't have a wide variety of classes of drugs available. Any drug could be used, and they could be used early in any kind of combination. And here the drug therapy involved, step 1 is the dual low dose combination with preferably half the dose of ACE inhibitor or ARB and half the dose of calcium channel blocker. The step 2 would be a full dose of ARB and a full dose of calcium channel. And step 3 would be the addition of diuretic, and step 4 would be spironolactone, similar to the prior guidelines. So what is really new is that please use longer acting thiazide-like drugs like chlorothalidine and indapamide. They have a good peak of action and their hyponatremia rates are lower. Single pill combination SPC should be used right at the word go in the first line treatment, preferably a combination of ACE and calcium channel blocker, or ACE with diuretic, or an ARB with calcium channel and an ARB with ACE. So the latest guidelines, as you can see, have slightly different definitions, but the treatment goal is the same. 130 by 80 is the treatment goal in all. A large amount of money has been used in the last 10 years for hypertension, resulting in a lot of deaths. And we really know that hypertension causes most of the stroke deaths, almost 60%, and 1/4 of the cardiovascular deaths. So we need to be careful. We need to look at the targets. And more importantly, apart from ACE, RB, PCB, and the thiazide, we need to use beta blockers in our patients and single pill combinations, which are easy to use and ensure better compliance. We need to make our diagnosis in out of office measurements. We need to look at the home blood pressure. We need to look at ambulatory blood pressure, and more importantly, start using automated office BP measurements to ensure that there is a less inter-individual variation. Thank you very much for your patient hearing.